Later on, when we have the questions, I will be I'll just answer to the best of my ability uh, based on what I read or experienced. And okay, so let's get going. Here's my building, and if you look at this window over here, this one, that's the one with the arrow there. All right, so that's where I am right now, speaking to you from Camden Medical Center. I'm in private practice. I have a group of, we are a group of 10 doctors. I work mainly with orthopedic surgeons and one neurosurgeon who does mainly spinal work. So I'm the only non-orthopedic surgeon, a non-surgeon in the group. I'm the only physician, and as a result, most of the non-surgical treatments get diverted to me. Quite a number of my colleagues as well have agreed to, they are into, they agree the concept of biologics. So I do get some fair amount of referrals internally. Now, I just wanted to say from the outside that if you look at this curve, and this is just as of today, the 27th of May, if you went to PubMed and you clicked in platelet-rich plasma, you'll have 11,868 references. And then if you look at the curve on the screen where they show you the growth of, the number of publications per year, you would just see it going up almost in an exponential way, somewhat like the way COVID-19 has taken over the world. So it's a huge upswing. Here we are in the first half of 2020, and it's already just about halfway compared to last year. So without a doubt, there's a lot of interest in platelet-rich plasma, and there's a lot to read. And of course, I haven't read everything. Now, I just want to bring this up, and those of you who have attended any of my lectures will always see this chair inserted in one of my lectures. The reason I put it there is because I just want to explain where I come from. So I'm a clinician, and as a clinician, I always practice something called clinical reasoning. And it's important to have this perspective in this era of evidence-based medicine, because we look at all those publications, but that's not the be-all and end-all. I think as a clinician facing a patient directly, this chair to me models what we need to do. The first leg of the chair is mechanistic reasoning, where we reason from first principles, whether it's a diagnosis or a treatment choice. Second thing is based on your own experience, where every case informs the next one you do. The result of one case informs the next, and as a result, the more experience you get, the more data points you have inside your head, and the more it informs you going forward. The third leg is what we see, what you can get in PubMed, the external evidence, whether it's RCT, uncontrolled trials, or even anecdotal evidence, or even case studies, if that's what's absolutely relevant to the sort of patient you're facing. And the fourth and often neglected one, at least in Singapore, is the patient's choices, the patient's and the patient's and your own values, which also factor in the choice of what to do and how to proceed. And with that in mind, I've approached PRP right from the start, and this is the way I do my daily practice when we try to figure out whether something is working, what we should do with a patient, right? And so the reason I say this is because and I'm pretty sure you experienced this in Australia as well. Sometimes you get guidelines, or you get people telling you that, oh, where's the RCT on this? Where's the publication? And it's not all about that. Publications are quite often done by grad students, and some of them have got absolutely no clinical experience. So I think as a clinician, we need to walk this middle line between clinical experience and publication, and what's external evidence. And we're always meant to take that sort of centrist path. Okay, enough about that. Now I'm going to jump straight in. There's a bit more reading to be done. It's all in the 90s. This is not my idea. It's actually at the birth of evidence-based medicine. This was the actual concept, not just to read studies and completely just believe everything you read, but to apply what you know with what you read. Okay, so back in the early days, this topic I'm talking about is very broad, so I've just taken the liberty of cherry picking a few things. This is really a condensation of a much longer lecture which I give, and Jeremy, it's a bit hopeful that I can finish it in 15 minutes, but I think
That's
it's more like
okay.
half an
Don't
hour.
rush.
Okay, so way back when I first started in 2008, I started tracking the results of my PRP on joints in patellar tendon, in osteoarthritis and chondromalacia. And so I did a little study of 45 patients and I presented it at a Bridge conference in Geneva. And in a nutshell, these were the results. We followed them up for about 4 months, and we found that a shot of PRP could reduce the pain quite significantly. In fact, to the 75% of the pre-injection levels. About 37% of them could hit that level, and over 80% could hit over 50%. So it was a very crude, simple study, just looking at pre and post pain, tracking them for about 4 months. And so we had chondromalacia, which was just patellofemoral, and we had more mild bi or tricompartmental OA. And the results were fairly similar. So this to me was really the start of me doing PRP, because I just needed to convince myself that PRP was doing something. Now, of course, there's no control group and all that stuff, but I think, so I'm going to jump forward now to the current evidence, and this is where we are right now. There is level 1. Level 1 meaning meta-analysis and RCT levels. And there are at least 20 RCTs out there now. Based on the current level of evidence, without going really into detail, I'll just say that it does show that it can provide pain relief. An intra-articular shot of PRP for osteoarthritis can provide pain relief for up to a year. Leukocyte poor is favored over leukocyte rich. And this is a very important paper to read if you are keen. It's by Jonathan Rebo from Cornell University in 2016. Multiple PRP injections are okay. Combination of PRP and hyaluronic acid is also supported. Now, what I did not write here was that PRP is considered very safe for your joints, provided you do it without any infection complications and so on. All right, so it is a safe treatment. There's nothing, some people do get a bit of irritation, but by and large, it is a very safe treatment. So here is the Rebo paper, and it actually looked at, the reason why I say it's a good paper is because for the first time, somebody looked at the kind of PRP which could help with osteoarthritis. So the first concept to understand for those who have not done PRP before is that PRP is not a singularity. It is not one substance. In fact, even if I prepare it exactly the same way in 2 patients, you will not end up with the same thing, because it is from the patient's own serum, own blood, and platelet counts do vary quite a bit between individuals. And even if 2 individuals have the same platelet count, you may not have the same amount of growth factors. So, that being said, what can we do then? How can we try to optimize all the sort of platelets you want to use, the sort of preparation we want to use? I think most of you who have done PRP are aware that the end product which you prepare is a lot dependent on your system, or on what system you use. All right, and they do vary in platelet concentrations and the amount of cellular material inside the PRP. Now, what Jonathan Rebo did was he took 6 level 1 and 3 level 2 studies with over 1,000 patients, and he separated them according to whether they were leukocyte poor or leukocyte rich. With the simple definition being, leukocyte poor was less than the native concentration of leukocytes. And where the material wasn't provided in the write-up, he actually went and called the authors, and he got the information. And this was a very good study because I think it showed very clearly that leukocyte poor significantly improved functional outcomes compared to controls, where such a difference could not be seen in the leukocyte rich. So to me, this was really the first study which showed that it was not a one-size-fits-all, and there was a preferred preparation you could use for osteoarthritis. Going forward, we might see further separation, further breakdown, but I think this just represents the first step. And I must say also that at this point in a lot of PRP research, a lot of it focuses or should focus on the type of PRP. So if anyone of you is doing PRP research, it's important to define the kind of PRP you're using, because one form of PRP may not be extrapolated. The results of one form you may not be able to extrapolate it using a different kind of preparation, right? So loosely you could, but the correlation may not be that great. Now, this is another, this is actually a very recent publication this year. And basically what it was, again, looking at is different kinds of injection therapies, this time for hip osteoarthritis. And again, over 1,000 patients. Corticosteroids, the most efficient in the short term, but PRP had the highest ranking for pain relief for up to 6 months. Okay, so there is quite a bit of level 1 meta-analysis of RCTs is a level 1 study, right? And in fact, even about 3 years ago, and again about a year ago, I think, in the journal, in the arthroscopy journal, there were editorial commentaries which talked about PRP. And this one in 2017 was the first one which actually addressed PRP. And it talked, and the title, as you can read, is "The Time Has Come to Try Intra-Articular PRP for Your Patients with OA." This was, in that same edition, was a very important meta-analysis, which again showed favorability towards PRP. Now, what about the combination of hyaluronic acid? And so this was a study which was published in Cartilage last year, and it showed that the combination could significantly increase the bone marrow stem cell and chondrocyte proliferation, and it decreased the expression of catabolic enzymes. So there seemed to be a greater effect. On some of these inflammatory factors, it was greater than using PRP or HA alone. So there is some basis to use PRP together with HA. And this is actually a meta-analysis of PRP. Again, if you separate PRP and HA, you see that both independently do have effects. PRP has the greatest point estimate, although there's a lot of variability. And that's because there's a lot of variability in the type of PRP. Whilst this is a bit less so with hyaluronic acid, where it's easier to define where they use a high molecular weight product versus a low one. And high molecular weight being defined as 1,500 kilodaltons and above. And it shows the current strongest and most consistent evidence. But you see that both of them do have some effect. This is a RCT, which is multi-centered, where they showed that, again, once again, the combination was better than each of them individually. Now, just a little plug for Region Lab. Nicole, you'll be happy with this. I do use this product. In some cases, it's a cellular matrix. It's a product where essentially it's PRP combined with hyaluronic acid. The hyaluronic acid is already parked in the tube over here, and you just add in the blood, spin the thing, mix it, and you can shoot in this mixture, which is a combination of PRP and cellular matrix. There are at least 2 good studies published out there now which show that it is efficacious. This is an interesting one because it was really just a pilot study, but it was just looking at intra-articular PRP for knee osteoarthritis combined with extra-articular PRP, and they did show favorable results as well. And I just highlight this because I do use PRP intra-articular mainly, but sometimes when we see ligamentous lesions in conjunction with the osteoarthritis, I might put a little bit of the PRP extra-articular into the ligament as well. I'm aware that those of you who come from a prolotherapy background probably do some PRP into the ligaments for tense integrity purposes and so on. I'm not formally trained in prolotherapy myself, so I guess that's more, there are better people than me to ask about that. Now, I just want to highlight a few more studies. One is that this was an interesting one because, cortisone remains the favorite thing which orthopedic surgeons love to inject into the knee. And they also love to inject local anesthetics. And both of these substances we know have pro-degenerative effects on the cartilage. They are a bit destructive to the articular cartilage. And what this study found, which was an in vitro study, it showed that PRP could improve chondrocyte viability when administered in parallel with corticosteroids or local anesthesia. So what this suggests is that maybe if you really wanted to use cortisone, you could use PRP concurrently to mitigate the bad effects of the cortisone. Because in many instances in our practices, we get patients who come in with very painful knees. It's very tempting to want to inject cortisone to relieve the pain. But, I'm always a bit cautious because I don't want to give a short-term solution and which results in a longer-term problem, which results in more degeneration in the knee. So possibly, if we did PRP concurrently with the cortisone, we might be able to mitigate against that. Now, there's no clinical study for this, all right? So I must caution you. And it is, I think, extremely difficult to get a clinical study on this. Okay, so what do I use it for? I use it for osteoarthritis all over the body. I use it for osteoarthritis in the ankle, the hip, other than the knee, the AC joints. I also use it for osteochondral lesions in the ankle, where there's a bit of chondral damage, if we are trying to find a non-surgical solution. And that's a separate lecture on its own. Sometimes I combine that with a bit of shockwave into the bone lesion of the osteochondral lesion. Okay, interestingly, I had a few patients where we had some before and after MRIs, and we actually saw in some patients the cartilage growing back after PRP. And this was the first time it happened. It was with a soccer player in the national squad. He's 26 years old, and he had a grade 4 cartilage ulcer with delamination under the patella. And we gave him pretty aggressively 4 PRP injections. In 3 months, he had no more pain, and a repeat MRI in 4 months showed the cartilage was back. The same radiologist, the same MRI center read it, and he said it looked like the delamination was gone. And this is another person. He's a recreational basketball player, and over the course of 4 years, over the course of 3 years, we gave him PRPs, and he started off with a grade 4, which was 2 by 1 cm, but at last year, a year after his last PRP, he noticed his pain had gone down a lot, and the ulcer had shrunk to 1 cm by 0.8 cm. So, it is difficult to prove that PRP grows back. Some animal studies suggest that there is definitely a pro-regenerative effect on the cartilage. But other than these very anecdotal studies, and I've had one of my colleagues actually looked at one of my patients. He happened to have an arthroscope pre-PRP, and post-PRP he played football and he tore his meniscus, so he went for a second scope, and he also found that there was cartilage growing back. And if you've listened to some of the presentations of some of the international faculty, I've heard some of them, the surgeons talk about pre and post scopes where they did see cartilage grow back as well. So I would never tell a patient that I guarantee your cartilage will grow back, but I always silently hold out that hope in my head. And, but to me, this is just, it does tell me that there is some kind of regenerative effect from PRP. And I must tell you that in my own experience, I've never seen it happen in any patient over 45 so far. The younger the patient, the more likely it is. So these are 2 patients. I've had a number of patients now where we have had a pre and post. Most of them actually don't show much change on the MRIs, but a few of them do show some improvements. And but it leaves me to wonder whether if I had a 50-year-old, should I be 3 times more aggressive with my PRP regime? And there's no data to show something like that. The problem sometimes is that when I start giving 1 or 2 or 3 PRPs, they clinically feel a lot better, and it becomes very hard to convince them that I should give you 10 in order to repair your cartilage, because I have nothing to prove that I can do that. Right. So this is where we are now. This is where I am with it. Okay, so just in a broad sense, again, the PRP for osteoarthritis, based on what we the evidence available, give an intra-articular injection, and this can give pain relief for up to a year, based on the current evidence. Leukocyte poor is favored, right? So PRP it improves functional outcomes. This is supported by level 1. Most studies show that early stages respond better and younger patients respond better. PRP injections, multiple are acceptable, and you can combine it with hyaluronic acid. Now, just some these are just some of the considerations in administering PRP. There are really a lot, but I just wanted to highlight these 4, to cherry pick these 4. One is that do pick the correct type of PRP, and in the case of joints, osteoarthritis of the joints, I would go with leukocyte poor. Try not to give LA where the PRP is, because local anesthesia tends to prevent platelet aggregation. So either very minimal or no LA at all. Right? Now, the last 2 points, PRP is location sensitive. If you gave PRP intra-articular, go for the joint space. If your needle lands up in the fat pad, the PRP is going to get engorged in the fat pad. It's going to activate inside the fat pad, and it's like giving PRP to adipose tissue. I suspect not much of it. You're not going to have much effect on the joint. But if you give it in the intra-articular space correctly, when you inject, there should be no resistance, and the PRP will flow around the joint. So after you inject it, you need to move the joint. The PRP is attracted to sites of damage. PRP gets attracted to sites of tissue damage. The exposed collagen tends to attract the platelets. So once the platelets go, they're attracted to a site of damage, they stick on, they become activated, they become adherent, they change in form, they release growth factors, they attract other platelets. So it's important to get to the correct location, at least the correct plane of the joint. I've seen people who inject PRP into synovial membrane, into fat pad, and I don't think it's as effective. And the biggest clue you would have is that as you inject, there should be no pain, because if you are very clean in the intra-articular space, there should actually be no pain. And this means if you have to guide, if there's an effusion, that's very easy to do, but if there's no effusion, and you can use an ultrasound to guide. The last point I put there was that it was time sensitive. So what happens if you inject the PRP into the fat pad, into say the retropatellar fat pad, or any of the fat pads around the knee? The PRP activates usually 75% within 5 to 15 minutes, and the rest within the hour. And if your PRP was not able to migrate out of that space into the joint space, then it's kind of wasted, right? So there's a time-sensitive element to the PRP, and later on in the presentation, you'll understand why I do certain things because of this time sensitivity. But I can tell you that these do play a part in the success of the procedure. So what you do immediately after the injection is quite important. As important as placing, the care you take to place the injection in the correct location. So for the injection technique of the knee, as I mentioned, intra-articular placement is essential, right? Extra synovial, extra capsular injections would just not work. They are more painful, you might get some adverse reaction, right? So this is just some data, right? If you, depending on the approach, the intra-articular injections are anywhere from 70 to 93% accurate. It's more difficult in an osteoarthritis knee. Your accuracy can drop pretty low to almost to about 56%. And the best route to use is the lateral patella and the lateral suprapatellar route. Okay, so these are the routes I use. They actually are the least painful. The surgeons like to bend the knee and go from the anterior route, but I always find that a bit more painful for the patient. Ultrasound guidance does provide accuracy. Patients need to be comfortable in position when you inject, and so I'm sure all of you have injected, and all of you have your favorite ways of doing it. I'll just share you mine, right? So this is the lateral patellar route. we actually go for the gap between the IT band insertion and the vastus lateralis into the lateral portion of the patellofemoral joint. I push the, with my finger over here, I'll push the kneecap laterally, and that way create a little bit of a gap, and then I push my needle in, right? And usually you feel for the give, and it should be very free flowing from that point. The only anesthesia I'll give is just using a 30 gauge half-inch needle. I might just put a bit of sub-Q anesthesia at this point once I've identified it. And then, so in some cases that totally makes the thing painless. Patients hardly feel anything. All right. So now in the more difficult patients, I go into the suprapatellar pouch. So this suprapatellar pouch, and here's a little video clip you can see. Okay, so PRP goes in rather invisible. I must confess, this is actually hyaluronic acid, but it does show very nicely in this picture. All right, that we are going into the intra-articular space, and this is the exact position, suprapatellar, the needle going in this way. Okay, let's go to the next one. I'm sorry. Okay, all right, so what about the hip? All right, so I'm just gonna, oops, sorry. So the hip is a deep joint. I'm not too sure how many of you inject the hips in your clinic, but there's a few important things to remember with the hip. Right? One is that it's a very congruent joint and therefore needs less volume. The excess volume you put in the hip just flows to the neck and away from the articular surface. The anatomical considerations are the direction of the femoral neck and something called the zona orbicularis, which is the ring of capsular fibers around the neck. And you should not inject anything below the zona orbicularis because it's not going to reach the neck. It's always recommended to imaging guide your hip injections, although there's some publications which talk about non-imaging guided methods. But once you encounter anyone with any form of hip dysplasia, then all that goes inaccurate. So imaging is always the best option. And so, okay, so here's the anatomy of the hip. Zona orbicularis can have a slightly variable location. And it's important to inject above the zona orbicularis. And if you look at the classic teaching of hip injections by ultrasound guidance, it will tell you to inject somewhere here. But then over the years, again, I found that it's actually, I seem to get better results by injecting directly into this gap. And I'll just show that to you. So this is how I do an ultrasound guided hip injection. So in the beginning, I was very obsessed with not hitting the femoral vessels, and so I would mark them out. I would ultrasound and draw a big line on the leg and mark it out. Nowadays, I don't bother to do that. I just feel for it, just make sure that it's far away. You don't want to be anywhere near it. Draw a line between the ASIS and the pubic tubercle, and about 2 inches down and 2 inches lateral, and that's where you start placing the probe. Now, the reason I like this position, this is with the patient supine, is that you can preserve all the modesty, or a lot of the modesty. So what I do typically is I just ask the patient to drop the pants a little bit, and they are wearing briefs or panties or their undergarments. I'll just pull it up and I'll tape it down here. And all I need is this little triangular space of exposure. That's all I need. So that's a lot of modesty preserved and very acceptable to all the patients. And this is the guidance line for my injection. Now, so yeah, there's a picture of me doing that. So you can see the area of exposure is very small. So when we put the ultrasound in that position, we can see the anterolateral component of the hip. And just as a sidebar, I do use it a lot for the labral tears as well, the small labral tears. If they are too displaced inside and so on, then probably need surgery. But most of them are very small and maybe just have a bit of degeneration. So this is the kind of view we get. If we just go further down, we can see the neck and the capsule, which is loose over this position. Now, a lot of the classic ultrasound teaching is to inject here. And this is very easy to do. It's slightly harder to do here. But injecting here, just bearing in mind what I said earlier about time sensitivity and location sensitivity, right? If the platelets activate here within the capsular area, the synovial area, they may not be much of an effect here in the articular surface. So what I do is I try and get it here, as much of it here as I can. All right. So this is where we see a fusion, and I don't have that video, but I can actually have a video of injection coming here. After we hit about 4 ml, whatever else we inject just falls backwards here. Right. So so this is the position I would normally inject. Right. Sometimes we do the ultrasound of the hip, we can see things like labral displacement. And in one of my patients who had a hyaluronic acid injection done by a rheumatologist, she said it didn't work at all. And when I scanned her, I found this big mass of what I presume to be hyaluronic acid outside the capsule of the hip. And we did an MRI on this to make sure it's not a tumor of any sort. And the reason why it didn't work was because it was extracapsular. So it's important to be accurate in the injection. All right, so this is the line I would use. So usually I would measure the line. In this case, it's 37 millimeters long. Just make sure that my needle is long enough. So actually, most of the time I end up using a spinal needle, other than for the very small patients. So what I do is I anesthetize superficially here. Then I bring the needle in. And every time I pass the septum, before I reach the septum, I'll shoot a bit of LA. So the needle comes in with a LA syringe attached first, and I'll shoot LA outside the capsule, and then I will bring the needle through the capsule and continue shooting. Now, in the case of labral tears, I might pepper the edge down here a little, just squirt a few drops of PRP out there first before I go in. All right. So usually with this method, it's fairly painless. Now, this is something which I do, which has not been validated by any study, but it's just a bit of clinical reasoning. So based on the direction of the neck of the femur, what I do post-injection is to lie the patient recumbent on the contralateral side. So we've injected the right side, I lie her on the left side, right? And the reason for this is because the direction of the neck is here, right? This is the direction of the neck, and we want gravity to help bring the PRP all the way, keep it in there. So if there's any fluid pulling, we don't want it to pull distal, we want it to pull proximally. All right, and then I'll flip them forward because again, the direction of the neck is that from proximal to distal, it goes anterior to posterior. So I'm trying to use gravity to help pull the PRP in the correct place. Now, when I put them down here, I do a bit of passive and active hip movement as well. So basically, I'm just trying to massage the thing around, move the PRP around, make sure it gets exposed to the articular portion of the hip. All right. So I spend a bit of time on this because I feel that contributes to success. I think noticeably when I started doing this, I felt that the patients were doing better. In the past, when I did a hip injection, after we have done it, needles out, okay, stand up, you can go off, you know. We just clean the needle hole, put our plaster, and off the patient goes. And, you know, can you imagine when the patient stands up and, you know, starts moving the hip, and the excess fluid pulls downwards at the neck, right? And what good is that going to do, right? It's probably not going to do very much if everything you injected pulls away from the articular surface. Okay, so now I'm just going to quickly cover PRP on tendons. Most of you know this already. There's an anti-inflammatory effect of PRP on tendons, and it found it reduces the PGE2. It induces stem cell proliferation, and there's some very good scientific reviews on the basic studies on tendon, decreased tendon repair time, etc., cell proliferation, and increased vascularity. And these are all basic studies on animal tendons and so on. And they show that it increased tensile strength as well if you do a repair of a tendon tear and you augment it with PRP. This was a good study. The reason I brought this up is because it was published in the Lancet, and you know, Lancet is probably one of the highest impact journals in the world. So this was a needle biopsy of 20 patients with ruptured TEA, tendon Achilles, and taken 6 weeks after treatment with PRP and controls. And what it showed was that there was actually higher cellularity, and basically all the histological findings showed that it was in a more advanced state of healing with PRP augmentation. And this was a good study on humans. Right? So, now, So this was again my own data back in the earlier portion of back in 2011 to 2013. I just decided to look back at 100 of the tendons I did, and basically looking for pain reduction following PRP. And because I was noticing that a lot of patients get uh, post procedure soreness, and so I just decided to do a little retrospective look at it. And these are all the tendons from various parts of the body. It was kind of a mix of all the different stuff I was treating. And post tendon pain reduction, you see it's a little bit of a bell curve, right? We had the biggest effect probably about at a 1 to 2 week or 2 to 4 week period, and as we went past 8 weeks, and this one went on for 3 months, so whatever didn't recover in 3 months, we just consider a failure. But the tendon, I was more interested in this actually, the soreness following PRP, and I found that it was mainly 1 to 3 days. Most of my patients had it for 1 to 3 days, but some would drag on for about 7 days or even more. Right. So this just gave me some important information, which is sometimes missing from the literature, to tell, in a practical sense, what I would tell a patient to expect after the PRP injection into a tendon. So we don't see this after a joint, right? If we do joint injections, we don't get post-procedure soreness very often. It's the exception rather than the rule. But I would say that for treating a tendon, it's the rule rather than the exception. Right? So I just prepare the patients for it. This was a summary of that little survey we did. It was presented at one of the BioBridge meetings as well, I think in 2014 or something. And basically about 2/3 pain reduction, and about half of them within the first 4 weeks. And more importantly, I think most of them experienced soreness, mostly for 3 days, some up to a week. So that's the takeaway for me from this. Now, those were the early days. So again, the very good studies, the good institutional studies and the high-level studies are now out there. You'll see that there are 4 meta-analyses and 4 RCTs at level 1. The tennis elbows were the subject of most studies. There were other studies done on patellar tendons and so on. And here's just a bit of a sprinkling of the literature. You can find it very easily with PubMed searches now. I just want to highlight a few studies in particular. This was done by Jane Fitzpatrick. I don't know whether she's listening in, but it's a very good study. Because, again, somewhat like Rebo's study, it drilled down to what sort of PRP works best in what situation. Now, what I didn't like about some of the other reviews, and here I'm going to badmouth the Cochrane review from 2014, which a lot of the detractors of PRP used to try to badmouth PRP. Now, that was a horrible study because it conflated so many different conditions, and came up with this conclusion that the results are mixed and therefore, there's no evidence for it. To me, that's just like saying, antibiotics don't work. Antibiotics for infections give you mixed results, and of course, what antibiotic did you use for what injection at what regime? So you just can't mix it all up, right? And I think what Jane Fitzpatrick did was absolutely correct. Picked one condition, chronic tendinopathy, and look at the kind of PRP which works best for it, similar to what Jonathan Rebo did, right? And this to me is the way to go for any review. You should not mix everything up because you will definitely get mixed results. And to me, like I said, tantamount to saying, physiotherapy gives you mixed results for back pain, right? Of course. Now, okay, so this one looked at tendinopathy again, and she concluded strong evidence that leukocyte-rich PRP improves outcome in tendinopathy. And this was part from her conclusions. 1 to 2 mils of LA injected prior to leukocyte-rich PRP superficial to the tendon. Peppering technique for tendinopathy. All right, you use a peppering technique, you fenestrate the tendon, and best to do under ultrasound guidance. And these are very important takeaways. Now, so that's for tendinopathy. Now, I must emphasize one thing. If you are dealing with an acute tear of a tendon, all right, in a healthy young athlete with a small partial tear in the tendon, I would not fenestrate the tendon. I would not pepper the tendon. I would go for the gap of the tendon. And the way I've been doing it now has changed about 4 times over the last 12 years. And I'm in the latest iteration of the way I do it. I actually do it with activation, with thrombin activation of the PRP now. Concentrated PRP, thrombin activated, going for the gap, trying to fill the gap and solidify the gap. And then I would put a platelet poor or not so concentrated PRP, maybe in the sheath of the tendon. All right. So we try not to inject normal healthy tendon intratendinously because there is some evidence that you create the tear, and you can actually see that if you did that with a normal tendon, you would actually split the tendon longitudinally if you inject intrasubstance in a normal healthy tendon. So even when I fenestrate a diseased tendon, I do it with very small amounts. Never a big bolus amount in any spot. All right. So I think so I just want to distinguish between the two conditions when we are going for a tendon injury. Distinguish between the chronic tendinopathy and the acute healthy tendon. Now, of course, a lot of patients come with chronic tendinopathy and an acute tear on top of the chronic tendinopathy. And in that situation, I'll treat it like a chronic tendinopathy with a tear, and I would actually put the activated thrombin activated PRP into the gap. Okay, so let's go back to some literature, and this is another meta-analysis published in the British Medical Journals, Open Sports and Exercise Medicine. And again, it showed PRP is more efficacious than control, possibly more efficacious in women. But again, they complained about the the quality of the studies and so on. Now, this is another meta-analysis and systemic review and meta-analysis of bias assessment, and this is a recent publication, and it's 2017. Only level 1 studies included, and again they concluded PRP may reduce pain. So most of with lateral epicondylitis and rotator cuff. So here again are my considerations. When I see a gap in the tendon, I used to just inject concentrated PRP in the gap and then fenestrate if it's a diseased tendon. But nowadays, I would consider activation if I'm sure there's a gap and it's a fresh tear. And you can tell from the ultrasound sometimes by how hypoechoic it is. I would use an anesthetic outside the sheath and then guide the needle to the lesion. So then you guide it to wherever you want to go. So tendinosis, peppering technique, acute tear, I would go for the tendon sheath. I would just shoot around the sheath, right? The next thing I would do then is keep the elbow still for the next 5 to 10 minutes. And if I'm doing a tennis elbow, I would lie them supine and keep the hand on the stomach. I'm sorry, this picture is blocking my words a bit. The reason for that again is so effectively the elbow would be this way, and you want to keep the platelets all the way up proximal at the attachment because that's where the lesion is. So what you do not want to do is, after having taken all that trouble to put the PRP in position, have the patient stand up, drop his hand, and start walking off, and the PRP starts tracking downwards before it gets activated, and you lose some efficacy by that, right? So this again is part of the important post-injection protocol. Now PRP for shoulder it's really it's quite complex actually, but suffice to say, okay, if you read the literature on it, most of the publications talk about PRP augmentation of a surgical repair of the rotator cuff. So there's quite a bit of that out there, and there's some meta-analysis of that, and essentially after everything, they found that there's no difference in overall scores versus if you did it as a surgical augmentation. Now, I've got a couple of takes on this. There are some studies which show that re-tear rates were significantly decreased. Okay, it's important to think why you would augment a surgical repair. You would augment it because you wanted healing to occur faster, to give you a stronger tendon earlier. But over time, that difference will get less and less. And over time, your endpoint is probably going to be the same. So So sometimes when you look at these perspectives, that's one perspective. The second is that, like it or not, we are not really able to test the tensile strength of the tendon post-surgically, because this is a human being. It's not an animal which we can sacrifice, dissect out the tendon and subject to a strain gauge and load until failure, because that's the only way of really testing the true tensile strength of the tendon. So all these studies use proxy scores, which are usually shoulder scores, which are a hybrid of functional and subjective parameters. And do these truly measure the tensile strength of the tendon? And the answer is no. They actually measure the amount of post-surgical inflammation, muscle spasm, and probably the how effective your rehab program is. So to me, the measures are not that great. In fact, the only measure was a secondary measure, which was the re-tear rate, which I thought was important, because the re-tear rate does reflect a little bit of the tensile strength of the tendon. And there are some studies which show there's a little bit of advantage with PRP. Okay, that's all I'm going to say about the post-surgical usage. Now, what about the non-surgical usage? And of course, one of the famous cases is Sharapova, where she was out and she used a lot of PRP and shockwaves and eventually got back playing. So we know that PRP is used a lot in the shoulder based on insurance billing. This is a study on insurance billings in the States. And so shoulder was actually number 2 compared to the knee. There were no studies of PRP for complete rotator cuff tears non-operatively. Most of these studies on PRP for the shoulder, for partial tears, did subacromial injections. All right. So I want you to think about that for a while. Subacromial injections for rotator cuff tear, which is very often in the articular side. Does that make sense? All right. So why subacromial? Why not intratendinous if it's a tear? All right. So that's what I found with all these studies, that they were not quite. A lot of studies did not quite target where they should be targeting, because if the partial tear was a deep tear in the supraspinatus, it was on the articular side, why would you go for the subacromial bursa? So I think now there are a couple. This is a pilot study which looked at the tendon, and I think this one was intralesional, right, and showed some promising results. This is a randomized controlled trial which did not show an improvement, right? So I think it's still a little bit out there, right? This one went into interstitial lesion and PRP versus saline. So I think there's a lot to be said about how to do it exactly. All right, now for myself, what I do is there are certain conditions which I would consider using PRP. One is rotator cuff tears, partial thickness and small gap full thickness. I would not do anything with a gap more than 1 centimeter or even 0.5. I think it starts to get a bit doubtful if it's a full thickness gap. All right. So I use it for tendinosis. I use it for small tears. I use it for slap lesions, only type 1 and 2. But where the lesion is displaced, type 3 onwards, I would not use it. I might use it for bank heart, which are non-bony bank hearts. I might use it for osteoarthritis of both the glenohumeral and the AC joint. And I might put platelet poor in the bursa as well. Not really PRP, but platelet poor, because has got more of an anti-inflammatory component. So I would not use it for the massive tears. Sorry, the title is missing, but this is what I would not use it for. All right, and dislocations and hypomobility, usually I don't bother. All right. So again, use ultrasound guidance, local anesthesia outside the tendon. If I'm going intratendinous, I would use very minimal volume, just about 1 cc in most cases. I might activate it with thrombin. I would concentrate the platelets usually, and I might put the PPP into the bursa. I might add cortisone if I think there was a huge bursitis element, or hyaluronic acid. Right? There is some evidence that the hyaluronic acid is equally as good as cortisone for bursitis. Once again, after the PRP, if we target a tendon, as a general rule, I tend to keep them still for a while after the tendon injection, because I really don't want them pushing the PRP. After we try to locate it precisely, I would try not to. I don't want them to push it around too much. And this is an important lesson I learned way back 12 years ago. After I did about 8 patients, I used to put them in slings, and about 4 of them ended up stiff. And I said, no more slings. So I stopped using slings from that point. And actually, I just encouraged them to move within their pain-free range. And I think the stiffness problem is reduced a lot. Okay, so once again, with tendons, again, the interesting question: can we use steroids with them? All right, because again, steroids are one of the most common things which people use. So corticosteroids with tendons. So these 2 studies actually addressed that. They are both in vitro. They showed that PRP did not interfere with the anti-inflammatory effects, and you may avoid the deleterious side effects of the steroid. So without going into too much detail, these are the 2 takeaways. Again, I emphasize in vitro. So theoretically, if you had to give a cortisone to a tendinopathy or tendinitis, you might want to consider parallel administration with PRP, right? Just to try and protect the tendon a little. All right, ligament tears, not that much written as the other 2. I'm finishing soon. There's no good meta-analysis for ligament injuries alone. Right, there is a scarcity of RCT evidence. So any of you who wants to do any research, this is a nice area waiting for more information. All right, so very limited studies. Again, one on high ankle sprains, which does show some favorable results. Again, most of it on high ankle sprains actually, and then one on ulnar collateral ligament tears. This is another one on ulnar collateral ligament tears, and which shows a drop in pain scores. All right, muscle tears, another interesting one. I do use it on muscle tears as well, but again, literature is a bit more scarce. This study was, I think, from Stanford, and it was an interesting one because it showed that platelet-poor plasma was actually more effective to induce myoblast cells into differentiation. So maybe we shouldn't be using too concentrated PRP for the muscles. And so I tend to keep it dilute. And again, here's some very limited studies. These are more the basic science studies, right? We know there's some positive effects pro-regenerative. And there are some clinical studies, and this systemic review and meta-analysis summarizes all 5 of them, which is not that many. And it's quite equivocal, I would say. It does show some favors muscle strains, except for the hamstring. So this is one of my patients. He's a tennis coach. He came with this. He came with a calf strain, the acute tennis leg, and with that you get a lot of bleeding, and you get this dissecting hematoma going up the plane of the gastroc, and we shot PRP in there, and 8 days later we could start seeing some fibrosis in there already. So I mean, I've seen good results with muscle tears. Just anecdotally, so I do use it as an option in an acute muscle tear. It's not a must-do; it's just to buy you some time, to shorten the timeline. This is another patient. He's a football player, again in the national squad. Gluteus attachment, and this was the initial pre-injection picture. After day 5, we had that, and by day 13, it was that. All right, so we track these patients sometimes, and clinically he did improve quite a bit, over the 2 weeks. On nerves, okay, so this is an interesting one. I think there are a couple of pain specialists out there. Now, I must say I don't do a lot of nerves. There are people in Taiwan and Hong Kong, I think, do a lot more. But there are some effects on the nerves. This has been studied in rat nerves and so on, enhancing regeneration. And enhancing recovery of the nerve muscle unit, etc. Right? this is a model from Michael Sanchez, and he proposed this 6 lines of evidence, of the effects of PRP on nerves. So I guess the bottom line is that if you are doing hydrodissection of nerves, if a nerve has been subject to some compression, sometimes we use hydrodissection with D5W, dextrose 5%. You might want to, at some point, consider PRP as well, during one of the treatments to use for the hydrodissection agent, right? Because if you think that there's some degeneration of the nerve after being compressed for some time. So in conclusion, I'd say that there's level 1 evidence for osteoarthritis and tendinopathy, and other MSK applications have lower evidence. Focus is currently on optimization of the PRP preparations, and it should be, I always emphasize accuracy of the injection and the time-sensitive nature of the injection, which is different from a cortisone injection, is different from a hyaluronic acid injection, right? PRP, because it's time-sensitive, you have to be accurate, right? Oh yeah, the last point I didn't want to forget saying this, that it's important to tell patients and to understand actually that PRP is purely a biological method. It's absolutely non-mechanical. You still have to do whatever mechanical things you want to do, with regards to the physiotherapy and so on. So I think it's part of an arsenal. It's part of your toolbox. It's not the only tool you should have. Everything else you are doing in conservative, non-surgical treatment still applies. PRP gives you a little bit of biological augmentation by creating a growth factor-rich environment where the injury is, and that's its main contribution. Thank you very much, and I'll take some questions now if there are.
Thanks, Dr. Goh. If anybody's got some questions, the group chats with so many people on might be the best way. Otherwise, yep. Raise your hand. Jeremy, did you have some listed with you from earlier?
Oh, thank you, Dr. Goh. That was great. I just had a question in regards to the concentration of PRP, and do you vary that based on the indications that you're using it for?
Yep, that's a good question. The answer is yes. Where we have some knowledge and evidence, I would. So in a nutshell, what I do now for osteoarthritis in the knee, I would use leukocyte poor. I would use a concentration. So Rebo's paper talks about not being too high. I think it goes up to about 2.5 times. But so like if I'm using the region kits, if you're using a BCT or THT, you probably get about 1.8 or so, and that's absolutely fine. So it's the simplest thing to do with the region kit, because you just spin it and you just take out whatever is there. Now, if I'm doing a tendon, let's say I'm doing a tendinopathy, a chronic tendinopathy, I would concentrate the platelets, and that's done. I tend to use the THT tubes. I understand you mainly use BCT there. I've done that. I've done it with BCT in Australia as well. In Singapore, I'm sorry, but I understand in Australia you use mainly BCT tubes, right? So what I do is after the spin, I put in my spinal needle and I withdraw, and so you can have a second needle to let the air flow in, so that there's no vacuum created. So you pop in a needle, then you pop in the spinal needle, and you suck out 3/4 of or half of that of the platelet poor, right? And that leaves you with maybe 1/4 left, and then you mix it, right? And when you mix it, then you'll get a higher concentration of PRP. Now, I like to use THT because if I want more cellular PRP, taking out 2/3 of the top of the supernatant actually gives me a cellular rich PRP, right? It brings up the cell count to over 1. And I don't throw away the PPP because you could use it as well. So if I'm doing a tennis elbow, I may throw away the PPP, but if I'm using the, if I'm doing a shoulder, I might use the PPP for the bursa, or I might put it intra-articular as well. Right?
Fantastic, yeah, that's great. I think there's a question here from Dr. Duncan.
Yep.
Did you want to, Dr. Duncan, if you want to unmute yourself, otherwise I can do that for you. There you go.
Okay, I was just going to ask Patrick, a lot of the patients with osteoarthritis of the knees have reasonable effusion, sometimes big Baker cysts.
Yep.
Do you tackle those?
Yes, sir.
Do you like to tackle them before you put the PRP in? Yeah.
Yes. Okay. Good question. Yeah, I do. If they come in with a big effusion, to me, okay. So the relationship, the problem with effusions in osteoarthritis is that you cannot suck them completely dry because the patient actually ends up more painful. A lot of them do. I take out what is under pressure. So if they come in some cases, I've taken out like 150, 200 cc's even, you know, in the really bad cases. But these are not the patients you would generally do PRP on, because these are the ones who probably need a knee replacement. So the milder cases may have a mild effusion. I would take out. It's a little bit of a judgment call how much to take out. I used to take out everything in the past, but I'll try and suck it out as much as I can. But I don't take out everything now. So I'll take off maybe half or 2/3 or half to 3/4 of it, and then I would put in the PRP. Now, as to the question of Baker cysts, I would usually aspirate the cyst first, right, and then do the PRP after that. Either on the same day or on a different day. But see, because the problem with the cyst is that it is a connection between the two. So you're going to lose some of your platelets to the cyst, right? So it makes it a little bit tougher. But I've aspirated the cyst first. I usually would aspirate the cyst first, and then I would do the PRP and, you know, put some compressive thing on the back of the knee just to try to prevent the redevelopment of the cyst and get the patient to rest, you know, so it doesn't come back immediately. Was there another question? Or that was it, right? Did I answer it?
Well, a follow-up question would be for a knee, OA knee, do you have a standard number of injections would you do? Would you just do the one? I know some of the series do 3 or, yes, you know, 2 or etc.
Yep. Okay. So if there's if I have a patient with knee osteoarthritis and there's grade 4 loss of cartilage, so that you actually have ulcerations, if you can see that either on the ultrasound, you know, so if you do ultrasound, right, you can actually bend the knee and look at the trochlear ridge, and sometimes you can see full thickness lesions there already. And so without an MRI, I already know there's full thickness in the knee. I would tend to do PRP 3 times. I usually tell the patients 3 times. It's not a hard and fast rule. I would do 3 times within 3 months. So it would be usually 1 injection every 4 to 6 weeks. And this is just purely based on experience again. 1 does give you some results. And what I found is that when, for many of these patients, 3 seems to give a more lasting result than 1. There is some literature to support that. I think there's now a study out there which compares 1 against 3, and they found 3 at 1 year having a much better result. So, but I'm prepared to stop at 2 if the patient is a lot better, and then I would defer it for 6 months. So the most typical protocol I use is 1, 2, 3, 1 month apart. Then I'll tell the patients, come back in 6 months. And then we might do a little booster. We'll see how you are and make the decision at that point. Now, but the caveat would be that if before 6 months you felt any recurrence of pain, come back earlier. All right. Now, in some patients, I would do 1, 2, 3, and the patients are telling me there's no improvement yet. Then I'd see them at 3 months or 4 months, and quite a number of these patients by 3 months would tell me that they have improved. Now, if they haven't improved by 3 months after my first 3 injections, I would actually suggest that you know, we either move on to something else or we try another booster, right? Now, there are many reasons why they don't improve, and you know, the pain in osteoarthritis. The problem is that the pain in osteoarthritis can be multifactorial. It's rather complicated. It's not always inflammation. Sometimes when we do ultrasound scans, a lot of pain is medial side of the knee. So the cause of medial-sided knee pain might be extrusion of the medial meniscus. It might be tenting up of the MCL. It might be some medial genicular nerve issues. It might be the pes anserine tendon, and it might be subchondral bone marrow edema. And last of all, it might be neuropathic in nature. So, and there are some studies which show that between a quarter and half of patients with osteoarthritis do have neuropathic signs as well. So, so evaluating pain is, so if the pain doesn't subside, the more I lean towards evaluating these other causes as well. And quite often I do combine PRP with some extra-articular kind of treatment, especially if the pain is localized, say to the pes anserine tendon. In some cases, you know, it cannot be PRP alone. It has to be with the physio. You know, maybe they're not doing, you know, the pes anserine, because the pes anserine, you know, takes 3 muscles, sartorius, gracialis, and semitendinosus. So in other words, extensor of the knee, an adductor, and a flexor of the knee. So whatever your knee does, the pes anserine is involved. And if your knee is being guarded because of osteoarthritis, the pes anserine is probably going to get a little bit inflamed. And we've seen a lot of this. And actually, my favorite method of treating the pes anserine in osteoarthritis is to blast shockwave at it. And that seems to work the best for me. PRP injections can be done as well, but the problem really is that it keeps coming back. And sometimes when the medial meniscus is extruded, it's very, very hard to deal with it.
Thanks.
Welcome.
Open the floor if anyone else has any other questions. We did have one come through quickly, Dr. Goh, just asking about use of PRP in lower back pain for bulging disc or.
Yeah. Okay. I will first tell you that I have not treated bulging disc with PRP personally, but I've been following it since the year 2012. And there's some good work being done in the US in the Hospital for Special Surgeries. I'm kind of following them. And so they have some protocols for that. I'm aware of some colleagues in Taiwan who do that as well, who do PRP in bulging disc. But I have not had any personal experience doing it. But the results seem to be favorable. So I'm just trying to remember the guy's name in New York, Dr. Greg something. I can't remember his last name. But he's done some work, and I think there's some protocols now out in the US. So I'm sorry I can't help any more with that, but I know it's being done. Yeah. Okay, so the reason I don't do it is because it's spinal surgeon's territory in Singapore. All right, so sometimes I am not too sure what the politics are like in Australia, but you know, down here I try not to step on too many colleagues' toes when I'm doing PRP. Yeah.
Someone else can answer that. Any other questions? I can't see anything else in the chat. A chance to unmute.
Okay, so with back pain, all right, so can I just expand on the back pain thing? Because I do treat the back pain if it is facet joint arthritis, all right? So the kinds of back pain I would treat with PRP, if there's evidence of facet joint arthritis, the facet joint is a joint I can see on the ultrasound. And what I can see on the ultrasound, I can usually bring my needle into it. So, and the facet joint is a synovial joint, and we can treat it like any other synovial joint arthritis. So that's what I do. If I'm convinced that facet joint arthritis is the main source of the patient's pain, then I would inject PRP. I would consider PRP injection for the affected facet joint, and we can do that under ultrasound guidance in the clinic. So the disc, I would. Well, most of the disc work is done in the theater in Singapore. I mean, under X-ray guidance by the radiologist. So I try not to step on their territory. But if I had a case and I would do it one day, I'd probably work with a radiologist, an interventional radiologist, and do it with them. The other reason I might do it on the back is actually things like trigger points, right? So sometimes we inject trigger points with PRP. I've got some patients who seem to tell me that that works better than anything else I use for trigger points. Okay, are there any further questions?
Nothing on my chat here, unless anyone else.
I've succeeded in putting everybody to sleep, have I?
Most are still on, so maybe not. We won't leave it there. Dr. Goh, thank you so much for your time tonight. I can see
Okay.
it's coming through to me, saying it's very helpful. If anyone has any questions that come from tonight, please feel free to reach out. I think you've all got my email from registering, but local reps as well, and I'm sure we can get back in touch with Dr. Goh with any questions as well. So thank you so much.
Okay, thank you.
Everyone.
Good night, and
Yep.
we'll soon.
Thank you.
Thanks.
Thanks.